Our next speaker, Dr. Pankaj Maheshwari from India, will speak on the topic of going smaller than 15 French in PCNL is advantageous. Over to you, sir.
Good afternoon, everyone. Friends, this was supposed to be a debate. Just last minute, it has got converted into a one-way traffic. So in my slides, you will still find some sarcasm at occasional places, which was placed there from debate point of view. Going smaller than 15 French is an advantage. Definitely it is. You see, it is very rare and probably in very limited urology field that size we would feel whether smaller size makes much difference. But in most aspects of surgical field, gone are the days when we said that big surgeons made big incisions. Today, definitely we do not want to see the large scar of pyelolithotomy. Even the large scars by large tract PCNLs look ghastly. What we want is a situation where the puncture should be so small that you probably need a magnifying lens to see those punctures. Where do we place PCNL if we have to just generalize it? So any patient with large and complex stone where puncture can be done, say he's not on anticoagulant, there is no bleeding tendency, would be an ideal case for PCNL. Other than that, there would be PCNL done for smaller stones, for small peripheral stones, if there are stones beyond an infundibular stenosis, stones in a calyceal diverticulum, post ESWL or post RIRS residual calculi, transplant kidney, and probably pediatric patients. So these are patients where I may decide to do PCNL even for smaller stones. This was a very interesting study where they looked at the quality of life of patients after 3 modes of treatment, that is ESWL, URS, and PCNL. It would be a probable thought that PCNL being more invasive should impact the quality of life more. But what was interesting to see here, that because in PCNL most patients have a assured stone clearance, a lot of them had a much better emotional and disease domain scores, and their ability to focus and work, family and interests returned much faster. So the quality of life after PCNL is much better, and this is because quality of life would definitely depend on post-op pain, length of hospitalization, complications, and whether we can assure him a proper stone-free status. Now, if we have to look at these factors definitely depend on the type of tract we made. So a tract, as we know, is a gateway for success for PCNL, and whether we talk of stone clearance, complications, and post-op morbidity, or is linked to the tract size. So why should we miniaturize? And how did this miniaturization business start? The first mini PCNL was done in a 2-year-old child where a 15 French Hickman peel-away sheath was used and a 10 French pediatric cystoscope was used to remove the stone. It was successful, and that was first time it was thought that probably going small in the tract size could be possible. A prospectively done study for small stones was done by Jackman at Johns Hopkins, and that is where they coined the term mini-PERC, where 7 procedures were done in 11 kids less than 6 years of age with a reasonably good stone-free rate and without any major complications. After this, there was literally a flood of multiple papers where mini PCNL was done, and mini PCNL was done for small stones, large stones, complex stones, anomalous kidneys, for calyceal diverticulum, post-transplant, and wherever you can do a PCNL, mini PCNL was done even for staghorn stones. So let's look at whether tract size really impacts parenchymal injury. This was one of the very initial papers by Oliver Traxler. That was probably a time when he wrote on things other than RIRS, where he looked at scar volume and parenchymal loss post large tract versus small tract. Though the difference was not statistically significant, but definitely a smaller tract led to a smaller scar volume and smaller functional parenchymal loss. Again, a very interesting study where the parenchymal volume was calculated, and it was seen that after a 30 French tract, the average loss of parenchymal volume was to the tune of 21%. Definitely, if we make a smaller tract, this parenchymal loss is likely to be lower. Does tract size impact stone free rate? Definitely no. Let's go as small as micro-PERC. Desai Saab, who has started this, is there with us in the audience. And even when you compare micro-PERC to mini-PERC, the success rate in properly selected cases for even smallest tract is comparable. Many studies, this one done by Dr. Madhu Agrawal's group, where mini and ultra mini were compared. Here, mini was less than 22 and ultra mini was 12 French. And here, the success rate was common, more than 95% in either of the arm. Again, a very interesting study where standard mini and ultra mini were compared for lower calaceal stones. All arms had more than 40 patients. What is interesting to see that with increasing tract size, the operating time is low. With increasing tract size, the hospitalization is higher, and with increasing tract size, the complications are higher. So if we go lower on tract size, we may spend few minutes, probably 15-20 minutes more in operation theater, but patient would spend less time in hospital and would have less post-operative morbidity. Does it impact intraoperative bleeding? A landmark study done by Rajesh Kukreja, where he had looked at all factors affecting bleeding, though there were very few patients where smaller tract was done in this study, but they alluded that a smaller tract would definitely reduce the risk of bleeding post-PCNL. Can we do mini for all size stones? Sven Lamme has presented a recent study, less than 5 centimeter square versus more than 5 centimeter square. What we see here is stone-free rate in both with mini PCNL is comparable. Transfusion rates are comparable, maybe slightly higher in larger stones. And overall, irrespective of size of stone, you can go low down in your tract size. Why are we fascinated by this miniaturization? And even the industry is pushing us in this direction. With a small knowledge of geometry, we know that if radius goes down by half, the area goes down by 4 times. So the smaller we go in the tract, the less parenchymal injury logically should happen. Practically all instrument makers have come up with mini PCNL equipment. There is an all-seeing needle for microperc. We have suctions which are attached to mini-perc equipment to keep the pressures low. Trilogy shock pulse come in very small probes which can be used through the smallest mini-perc equipment. And most importantly, when we remove the stone fragments, you do not need baskets or forceps. They come out through vacuum effect. So if we have to compare mini and standard, I'm sorry, we can say that for mini PCNL, most often it's a single step dilatation, so dilatation will be faster. The chance of recurrent dilatation steps and injury will be lower. Stone-free rates are comparable. The need for nephrostomy in mini PCNL will be very, very low, and overall transfusion rate will be much lower. Is there any problem with going small? One of the major problems suspected is probably the smaller you go, the higher are the pressures you would generate in the pelvic glacial system. It is likely that these pressures may be sustained for a longer duration of time, which may have impact on the renal function as well as the probability of infection. An interesting study done where they instilled E. coli inside the pelvic glacial system of a pig, and then a 1-hour surgery was done by a standard and mini arm. What they found was that in mini PCNL, the infection spread not only to the kidney, but also there was a hematogenous spread, and infective material could be found in spleen and liver. What does this mean? Thank you so much, madam. What does this mean? This doesn't mean that mini PCNL would increase the risk of infection. This would just mean that we should avoid doing surgery in presence of infection. If there is infection in patient's body, whatever type of surgery you do, there is a possible of flare-up of this infection. It has been found in larger studies that the blood transfusion rate, fever, and UTI are not raised in mini PCNL, and success rate is maintained. So we can say that a time has come where we have to reduce the tract size. The lower we go on tract size, the lower injury we cause, the lower blood loss happens. The OR time may be slightly higher, but length of stay would be better, and there is no difference in fever. It has gone to the extent of saying that mini PCNL should compete not with standard PCNL, but with probably RIRS and URS. Because even in RIRS, when RIRS is compared to mini PCNL, the stone-free rate with mini PCNL is higher, The hospitalization may be same. Blood loss may be marginally higher, but more assured stone clearance with mini PCNL. Further, when I do mini PCNL, the procedure is not long and tedious, more often in single stage, can be done in complex situations, and definitely I don't take the risk of causing any injury. Is there still a place for large tracts? Yes. If stones are complex, large tracts can be made. They may have some risk of injury, but then finally time has come where although size matters, we need to choose wisely. It is no use trying to treat large stones with smaller tracts, and it is definitely no use trying to treat small stones with very large tracts. So if we choose properly and give what is right for the patient, that is where we should be heading. Thank you.